The following podcast is part of a certified educational activity titled Gaining an Advantage over NSCLC, How to Achieve the Greatest Benefit with Immunotherapy from Advanced to Early Disease. Access the entire activity and complete the post-test at peerreview.com/RGK860. Downloadable slides and practice aids are also available.
Hi, everyone, and good evening. My name is Dr. Rupal Basuroy, and I am the Executive Director of Research at Longevity Foundation. Thank you so much for joining us for this immunotherapy CME in partnership with PeerView. Today, I'm joined with my colleague, Dr. Amy Moore, who's the Vice President of Global Engagement and Patient Partnerships. Amy and I are really sad that we are not in person with you at ASCO this year and hope your ASCO is going really well. At Longevity Foundation, we have two goals. The first goal is to improve outcomes for people diagnosed with lung cancer, and the second goal is to improve how people are living with the disease. At Longevity Foundation, we consider optimal care for lung cancer to be biomarker-driven, and immunotherapy is a key component of biomarker-driven care for lung cancer. We define biomarker-driven care starting right from pre-diagnosis to diagnosis, including treatment and potential progression. And the foundation has programs and services along this entire spectrum of care. To start off, we have a wide plethora of survivorship and support services. On the left, what you see is a lung cancer helpline that's staffed Monday through Friday at different times, and you can see the phone number there to access our helpline. We also have peer-to-peer support in the form of lifeline support partners and clinical trial ambassadors. In addition, we have a robust clinical trial finder, which is web-based, and it helps patients with lung cancer navigate the clinical trial space. In terms of our patient education services, we firmly believe that patients and caregivers learn through different mechanisms, and this is the reason why we provide patient education through different formats. To start off, our very comprehensive Lung Cancer 101 websites. To complement our websites, we have videos on specific topics. We also have booklets. And on the right, what you see is a tear-off sheet, which has questions to ask your doctor. All of our patient education resources can be accessed through this website that you see on the top. Now, what you see on the left are our comprehensive booklets, including a booklet on immunotherapy. And these booklets provide detailed information about different treatments, different types of lung cancers, for patients or their caregivers. Now, what you see in the middle are brochures and flyers. Now, brochures and flyers are simplified versions of what you find in the comprehensive booklets and summaries. And last but not least, what you see on the right are our lung cancer basics. These are our health literate education materials available both in English as well as Spanish. And with that, I'll hand it over to my colleague, Dr. Amy Moore.
Thanks, Upal. As you heard, we have a lot of different educational materials, and this goes to our website where we provide a lot of detailed information explaining immunotherapy, what the immune system is. We also provide nice videos. This one is, in fact, about immunotherapy and explains what it is and how it works on the lower left there. As Upal said, we have recently updated our immunotherapy booklet. We know that immunotherapy is now moving from late stage lung cancer into the early stage disease setting. And so our recent updates address some of those advances that are occurring as well. And then on the right, you can see that there's the patient journey sheet where patients can find specific questions to ask their doctors according to where they are along that journey continuum. And again, these booklets are available in both Spanish and Mandarin, and you can access them at the website shown. I also want to touch on a more recent offering for our patient and provider community called the Longevity Lung Cancer Patient Gateways. These are tailored portals for people with lung cancer broken out by biomarker or by subtype of lung cancer. And it's where patients can get more information about their type of lung cancer, connect with their community, and access educational materials and resources. So to date, we have launched gateways for KRAS, for general non-small cell lung cancer, ALK, and EGFR, and we'll be delivering additional gateways this spring on rare mutations and fusions, as well as small cell lung cancer. So this is a great resource, again, for patients and for providers to allow their patients to learn about the latest going on in these particular types of lung cancer. So we encourage you to check that out. And again, we thank PeerView for the opportunity to partner with you on this CME today, and hope that it is informative and that you again have a productive ASCO. Thank you.
Evening, everybody. It's great to be here. Thank you for coming tonight. Our topic tonight is on lung cancer. There's a lot of developments in lung cancer. Things change virtually monthly in lung cancer, and we have a great program today with some great people and then me. I'm David Carbone. I'm a medical oncologist at The Ohio State University, and I'll be the moderator tonight. And I will, like my other speakers, to introduce themselves. And let's start with Julie, who is with us live but virtually. Julie, would you introduce yourself?
Hi, good evening. I'm Dr. Julie Bramer. I'm a professor of oncology at the Johns Hopkins Kimmel Cancer Center in Baltimore, Maryland.
All right, thanks, Dr. Bramer. Dr. Peters?
Hi, Solange Peters. I'm the chair of medical oncology at the Lausanne University Hospital in Switzerland.
Dr. Sapezi?
And my name is Boris Sapeshi. I'm a thoracic surgeon at MD Anderson Cancer Center.
So we'll start with two portions of this program. The first part will be a discussion of some recent changes and issues in immunotherapies for advanced and metastatic lung cancer, but the majority of the program will focus on expanding those options and bringing them into earlier stages of non-small cell. And as I said, we'll have opportunity for questions and answers and discussion and thoughts about where the field is headed, and we really would appreciate your input and discussion there. So longevity is a major partner here, and longevity is the largest funder, foundation funder of research in lung cancer. Has been around for many years, founded by Andrea Ferris, whose mom died of lung cancer. And they've really been one of the leaders in the patient foundation space and supporting patients as well as lung cancer research. And also Upal is I think, listening tonight. And he was the one in the video you saw a few minutes ago. They are, in addition to their functions with physicians, they have a very active patient support portal. And so you should consider pointing your patients in their direction for their patient-related aids on their website. And they hold events around the country. So this is their examples of screenshots of their patient-facing immunotherapy educational material that's on the website. So we'd like to start out with the discussion of metastatic disease with Dr. Bramer, who's very well known, published the seminal New England Journal paper on nivolumab years ago, is currently the chair of the ECOG Thoracic Committee, a very influential thought leader in this field. Julie?
All right. Well, thank you very much, and thanks for having me. We're going to briefly discuss advanced disease, but like Dr. Carbone said, the exciting changes most recently are moving the immunotherapy in early stage disease. But we'll first lay the foundation and show you the lay of the land in metastatic disease, and also briefly just touch on some of the new data that has come out or will be coming out here at ASCO. So why are we discussing this topic? There are some gaps and opportunities for improvement. We know that immunotherapy, either alone or in combination, has demonstrated improvement in outcomes, including overall survival in first-line treatment for non-small cell lung cancer. And as these options and combinations are approved, there's multiple options, and it is a challenge for us to navigate amongst the options about what is best for our patients in the clinic. And just for an example, a retrospective analysis of real-world patient data from the Flatiron database found that about 20% of patients actually only receive first-line chemotherapy without IO, and these patients tended to have squamous cell histology and low PD-L1 expression, so less than 50%. So again, I wanted to go over some cases, look at some variations in practice, and try to improve our knowledge based on this. Obviously, in the first-line treatment setting, multiple options have been approved since 2016. You know, this is exciting areas of change, starting off with single-agent pembrolizumab, then in combination with chemotherapy, particularly for non-squamous cell histology, including a 4-drug regimen that was approved based on the Empower 150 for non-squamous cell histology. And then moving pembrolizumab into the first-line treatment setting in PD-L1 positive disease, and then various other combinations, and now even IO combination, nivolumab and ipilimumab, which in the US is approved for patients with PD-L1 positive disease based on the Checkmate 227 study, and then the Checkmate 9LA combining chemotherapy with Nivo and Ipi. And now we even have more single-agent therapy options in the first-line treatment setting with atezolizumab and cemiplimab, now rounding out different options in the first-line treatment for patients with PD-L1 high disease. So obviously, we look forward to continuing to improve options for our patients, and so that's why I wanted to go over some of these cases. So everyone get ready. I will be asking some questions. Now, navigating the broad range of immunotherapy options, you know, as we just talked about, I used, besides histology, PD-L1 positivity. So the higher the PD-L1, the more likely your disease is responding to single-agent immunotherapy. And obviously, for patients with PD-L1 high disease, we have these three different PD-1 or PD-L1 antibodies that are now approved for use. Clearly, in patients with low PD-L1 or PD-L1 negative disease, we typically recommend a chemotherapy combination, and we have various different combinations based on histology, either squamous, which is really relegated to pembrolizumab plus a taxane plus platinum combination, but in non-squamous cell histology, we have multiple options. And then again, like I said, nivolumab and ipilimumab is approved for use in PD-L1 positive disease, but does have compendia listing in the NCCN regardless of PD-L1 positivity. So I need some help. So for PD-L1 high disease, this is a gentleman that I recently saw in clinic. This is a 72-year-old gentleman who quit smoking about 35 years ago, was found to have a 3.4 centimeter right middle lobe mass on a coronary calcium scan. And his physician went ahead and ordered a PET scan. And at that time, he was found to have a 3.4 centimeter right middle lobe mass, right hilar subcarinal adenopathy, as well as bone metastasis. His MRI of his brain was negative. And he has some comorbidities, hypertension, gout, hyperlipidemia, but really was asymptomatic at the time of diagnosis. But now, in retrospect, he's noting some mild left upper back pain. Pathology, he underwent an EBUS and was found to have metastatic poorly differentiated carcinoma, having both glandular and squamous features. He has patchy TTF1 positivity, but negative for P40 and napsin-A. Mutations have come back with the KRAS G13D, and his PD-L1 tumor proportion score is 100%, and his PET scan is notable on the right. So, what treatment would you recommend for this patient? Single agent PD-1 or PD-L1 blockade? 2, nivolumab and ipilimumab? 3, pemetrexed, carboplatin, pembrolizumab? Or 4, sotorasib? 5, I'm not sure. So let's just talk briefly, and I'll kind of go through my thought process, but I'd love to hear Dr. Peters, Dr. Carbone, and even our thoracic surgeon would love to hear your thoughts. My thought in this particular patient with high PD-L1 and not a ton of disease and pretty asymptomatic, my thought was to go with single agent PD-1 or PD-L1 blockade. Now, obviously, these other options are appropriate, though I gave some pause on the pemetrexed, carboplatin, and pembrolizumab just in the fact that he had glandular as well as squamous features. So I might, if I decide to use a chemotherapy combination, I might go with a taxane, platinum, and pembrolizumab. And sotorasib right now just has an indication for second-line treatment, and he does not have a KRAS G12C mutation. It's G13D. And then obviously nivolumab and ipilimumab could be an option as well if he wanted. However, the nivolumab and ipilimumab, when you look at a breakdown by PD-L1 status, it has a very similar response rate as well as hazard ratio compared to a single agent PD-1 or PD-L1 blockade. I don't know, Dr. Peters, would you use something else, or what are your thoughts?
Thanks a lot, Julie. I would fully agree, right? There are few circumstances in which, in my practice, I would give up the idea of having a chemo-free regimen in high PD-L1, of course. There are some situations which we can sometimes discuss. This is about the need of having a very fast effect, response, relief of pain or symptom. And this is what we call the dangerous situation, where any growth, any time, any delay might lead to progression and death. But I must admit the situation in daily practice are extremely rare. So maybe 5-10% of our patients need chemo with the IO in high PD-L1. So I fully agree with you. I think that frontline strategy for these patients, whatever the meta-analysis we can see these days at ASCO, I think we have to also think about quality of life, and daily life is good when you can, I would say, delay chemotherapy.
Yeah, I also...
Go ahead, Dr. Carbone.
Sorry. I would also fully agree. Clearly, sotorasib is wrong in this patient. The other options you could argue about, but you have to be clear that sotorasib is for G12C only. And it's not just the second line issue, but it's a completely wrong option. I would choose for this patient single agent PD-1 blockade. Ipi-Nivo may have a reasonable response rate and outcomes in this population, but it does have more toxicity. And I do think that we have to make that balance of efficacy and toxicity in our patients. And that applies to the chemo-pembro combination as well. The response rate is slightly higher with chemo-pembro. So like Solange was saying, if you have a 1 millimeter right mainstem bronchus opening, and if it grew a bit, they'd collapse their whole right lung, then that may be a reason for getting a little bit higher probability of response with the chemo-pembro. But that is an uncommon situation. And in my practice, I would tend to use radiation if it really was an impending emergency, because there your response rates are even higher than chemo-pembro. So I would say most of the time I use the single agent PD-1.
I agree. I think the interesting data this year at ASCO so far is the FDA pooled analysis looking at single agent IO versus chemotherapy IO in the patients with high PD-L1. And in there, they showed there really wasn't a statistical difference from an overall survival standpoint between the two regimens in this patient population. However, it did tend to be higher. The median survival was more like 25 months versus 20 months. 25 months in the chemo-IO treated patients versus the single agent or this IO only group. Interestingly, though, like Dr. Carbone said, in this pooled analysis, it was a significant higher response rate. And interestingly, in some subgroups, the elderly patients actually did better with single agent immunotherapy. So obviously, this is a lot of caveats to a pooled analysis, but very interesting data.
Can I make a comment on that, Julie?
Yes. Yes.
Just one, in general, I'm trying to avoid median survival as the metric of success for these trials. And I really think that we should be looking more toward landmark survivals, out 3, 4, 5 year landmark survivals for our metastatic regimens. And you'd never hear that statement 20 years ago because nobody would be alive. But now we're seeing significant tails of curves and survivals. And I actually think these two regimens would have very similar tails of curves.
Absolutely.
And the medians can be misleading, especially with immunotherapy trials where you tend to have a rapid drop-off with immunotherapy.
Those are great points. Definitely with a 5-year survival of 30% in single agent IO in this patient population, it's hard to beat, and we'd love to see some long-term survival data in the chemo IO combinations. All right, now we're going to go ahead and recheck. How would you like, let's see how you do from a repeat, see if we can convince you one way or another. So based on what you heard, what treatment would you now recommend for this patient? 1, single agent PD-1 or PD-L1 blockade. 2, nivolumab and ipilimumab. 3, pemetrexed, carboplatin, pembrolizumab. 4, sotorasib. Or 5, I'm still not sure. All right, so let's take the second case for PD-L1 intermediate. So this is a 77-year-old woman who presented with progressive shortness of breath on exertion and hoarseness. She has a 10-pound weight loss, cough, left neck discomfort. She actually first saw an ENT who, because of hoarseness, found a paralyzed left vocal cord, and her physician then ordered a CT scan showing bilateral pulmonary nodules and bulky mediastinal adenopathy. EBUS was positive for adenocarcinoma, TTF1 positive, PD-L1 tumor proportion score was 10%. She actually has a 10-pack-year smoking history and quit about 25 years ago. Her mutation testing came back with a KRAS G12C co-mutation with P53 TMB high. And before starting therapy, she was admitted for rapidly worsening shortness of breath and was found to have a large pericardial effusion, which required emergent paracentesis and pericardial window placement. So she finally comes back to your office after being admitted. And what do you recommend for therapy? 1, single agent PD-1 or PD-L1 blockade. 2, nivolumab and ipilimumab. 3, pemetrexed, carboplatin, pembrolizumab. 4, sotorasib. Or 5, I'm not sure. All right, so from my standpoint, I gave actually pemetrexed, carboplatin, and pembrolizumab. I did not go to sotorasib up front based on FDA approval. And nivolumab and ipilimumab could be used, but I felt that I really needed that 60% or close to 60% response rate. Certainly single agent PD-1 or PD-L1 blockade could be used, but I definitely get a little nervous based even on some older ASCO pooled data from the FDA that did show that chemotherapy and IO did perform better than single agent PD-1 in patients with PD-L1 low or intermediate positivity. Dr. Peters?
Thank you.
Else?
An interesting case, because when you look at this patient who has a very old smoking history and what we call I wouldn't say a light smoking, but it was at the limit, only 10 pack years, but all the feature of a heavy smoker, a KRAS mutation, a high TMB. Mm-hmm. So let's consider that the patient lied on her smoking history because it doesn't look to be compatible. If he was a smoker,
we never see that.
So, well, let's say smoking habit was a feature of this tumor, because otherwise you always question, remember, the only time where you should think about chemo is when a patient is never a smoker, because the number of neoantigen to present to the immune system is low. But it might not be the case of this patient. So here I would also probably, in the strange history, favor chemo IO, because it's the safe way to go. If you cannot make the truth come out, I would use chemo IO. I still like a lot, for me, the Nivo EP. I'm convinced about the idea that this combination, which is still chemo-free, would the disease not be threatening again, because some progression or inflammatory process can happen, gives rise to a nice plateau of more than 20% long-term, which is really something to me which is attractive for me and for the patient. I will still wonder if CTLA-4 doesn't bring this plateau slightly higher than without. So 227 or 189, Ipi-Nivo versus chemo IO. If really he's a smoker, I would favor Ipi-Nivo. One thing which is important that about sotorasib, it's not only about the fact that it's at the limit of the competitive response rate with chemo IO, and not only because it's a second line treatment, but also because when you allow your patient to progress once, you might lose your patient when he progresses, right? And if you start with sotorasib, you remove from this patient this chance to be long-term controlled by immunotherapy, which is between 10, 20, 25%. So you should always start with the best hope and the best option first, just not to remove this chance. So even if sotorasib is pretty good drug, it's a second-line treatment there.
So there's a reason why you're president of ESMO. But that's a really good point, that everything isn't response rate, because sotorasib median progression-free survival is quite short, and we don't know what the 3, 4, 5 year landmark survival is, but it's really low. So I would definitely start with IO in this case.
Yeah, so interestingly, that's what we actually started with IO chemotherapy.
Well, IO chemo is what I meant.
Yeah, we did IO chemotherapy. She did well for about 15 to 16 months, and then we put her on a trial with a combination with sotorasib, and she's gotten about 9 months now progressing, so about kind of like what you would have thought. So based on our discussions, what would you now recommend? 1, single agent PD-1 or PD-L1 blockade. 2, nivolumab and ipilimumab. 3, pemetrexed, carboplatin, pembrolizumab. 4, sotorasib. Or 5, we've just confused you. All right. And this last case. So this is a 77-year-old smoker presented to the emergency room with 1 month history of progressive confusion. MRI was positive for a 3 centimeter frontal lobe metastasis. As sometimes happens, they go straight to neurosurgery. He had this resected, was found to have a solitary squamous cell carcinoma, and PD-L1 was negative. Once he got back onto the floor, a CT scan revealed a large left lung lesion eroding into the left chest wall, as well as some right rib metastases. And once in the office, he was back to his baseline post-surgery, ended up having post-op radiation therapy. He has comorbidities, including COPD and coronary artery disease. And so what would you recommend for treatment for this patient with PD-L1 negative disease? Single agent PD-1 or PD-L1 blockade, nivolumab and ipilimumab. 3, pemetrexed, carboplatin, and pembrolizumab. 4, paclitaxel, carboplatin, nivolumab, and ipilimumab for 2 cycles, followed by nivolumab and ipilimumab. Or 5, I'm not sure. All right. Well, my thought process through this patient with PD-L1 native disease, obviously single agent PD-1 or PD-L1 blockade in the first line treatment setting for PD-L1 native disease is really not appropriate. The pemetrexed, carboplatin, and pembrolizumab I ruled out because he has squamous cell carcinoma. And so that leaves us with either 2 nivolumab and ipilimumab or 4 paclitaxel, carboplatin, nivolumab, and ipilimumab for 2 cycles followed by nivo-ipi. I did not include the taxane, carboplatin, and pembrolizumab as an option, but certainly that could be an option as well. I think in the U.S., based on FDA approvals, I tend to lean in squamous cell PD-L1 negative to the Checkmate 9LA data of paclitaxel, carboplatin, nivolumab, and ipilimumab. I've been very greatly surprised. Getting patients through 2 cycles of chemo with this regimen is quite easy, and so actually that's what we did. Dr. Peters, your thoughts on this case?
Thanks a lot. That's a point of debate. Do you need the CTLA-4 component, right? So the basic regimen will have chemo, it's squamous, and the checkpoint anti-PD-1 or anti-PD-L1 is certainly needed. The question is CTLA-4, yes or not? I'm pretty convinced that there are few circumstances in which it has been consistently demonstrated that it might add something, even long term. The first circumstance is precisely these PD-L1 negative tumors, which always do slightly lower in terms of result, PFS, OS, and response rate as compared to all the other categories, whatever you use, except when you use CTLA-4. And that's what the topic of the Nobel Prize of Jim Allison. When you give CTLA-4, your tumor will immediately result in what we call an interferon gamma signature, response, and expression of PD-L1. So you compensate for that. The other thing is brain mets. We don't know why. It's a mechanistic, probably due to the microenvironment modification of the tumor. But it's interesting to see that CTLA-4 adds a lot of efficacy against brain mets in melanoma first, and now also potentially in in lung cancer with brain metastasis. So for this patient who presents with negative PD-1 brain mets, I think 9LA is pretty appropriate.
Dr. Carbone, your thoughts?
Very much along the same line. I'm not 100% convinced that the 2 cycles of chemo adds very much in this setting, but it is the only approved setting. It should be pointed out that in Keynote 407, which is the chemo pembro in squamous, in the PD-L1 negative subset, in the final survival analysis of Keynote 407, there was no survival benefit to adding pembro to carbotax, whereas the survival with both the ipi-nivo and the chemo ipi-nivo studies showed very durable survival in this subset. So I would strongly favor, even if you had carbotax pembro as an option, I would favor one of the nivo-ipi combos. And there's now good retrospective data about durable intracranial control with that combination, as you point out.
All right. Interestingly, that's what we did, and he actually did extremely well with the CTLA-4 PD-1 combination for several years because he was actually on a trial. So, but now, based on what we've discussed, what would you now do for this patient? 1, single agent PD-1 or PD-L1 blockade. 2, nivolumab and ipilimumab. 3, pemetrexed, carboplatin, pembrolizumab. 4, paclitaxel, carboplatin, nivo-ipi times 2 cycles followed by nivo-ipi. Or 5, we continue to confuse you. Thank you very much. I just wanted to just briefly wrap up. There are several algorithms for metastatic disease with no actionable genomic alterations. This is one basic one using PD-L1, but also want to note this amazing treatment algorithm that also includes information about survival, progression-free survival, and response rate developed by Dr. Desai and Dr. Ho. That is, are some practice aids that is in your information here tonight that you can directly download this algorithm. So, and it's great and handy if you need something to refer back to. And certainly in here in ASCO 2022, like the data that we talked about before with the pooled analysis from the FDA in patients with PD-L1 high, there will be some long-term survival outputs here this year for Checkmate 227, a 5-year survival outcomes, and that will be presented at the poster session on Monday. And then also Checkmate 9LA will have a 3-year update that will also be presented at the poster session on Monday. So I'm going to hand it back over and now let our folks expand immunotherapy into early stage settings for non-small cell lung cancer. Thanks, everyone.
All right. Thank you, Dr. Bramer. Now we'll move on to moving these treatments into earlier stage with Dr. Peters.
Thank you. So it is a very, I would say, innovative field of development of immunotherapy, not only in lung cancer, across diseases. We'd like to look at the opportunity of adding to surgery with curative intent, which remain the primary treatment for all patients with resectable stage 1 and 3A. We'd like to discuss how we could improve the current outcome of chemo and surgery by adding immunotherapy. There have been lots of barriers in the development of adjuvant treatment in lung cancer, probably the lack of new strategies, but also the problem of the lag time you always have to face when you launch an adjuvant trial. In lung cancer, probably little less than in breast cancer, but still it's long-lasting trials. So we tried also to identify new endpoints. How can you measure the benefit before you observe relapse in a minority of patients you hope? This will be discussed by the surgeon too. How can you potentially define innovative endpoints? And of course, how we can, in that setting, work better together. It's not only about chemo or immunotherapy, it's about how it can combine with the other colleagues. So now we'll discuss how we are making together this transition to from the data presented by Julie to early stage, and how we can try to manage the sequencing and the multimodality, the multi-professionality, which is needed to drive the new decision-making process. So basically, this is a summary. I love this slide because if you have it, you have everything there. At the time being, it will change over time. But we have in lung cancer a certain number of adjuvant trials and a certain number of what I would say neoadjuvants. Remember that in the neoadjuvant, some call it also neoadjuvant or perioperative, but basically something before surgery. So if you look at the adjuvants, there are 2 ways of giving adjuvant immunotherapy. The 2 ways are with or without chemotherapy. So we had one trial which was mandated adjuvant chemotherapy. It is the IAM Power 10, I will discuss later on, and has given results that we will discuss later on. The other option is to let the investigator decide for adjuvant chemotherapy, and this is all the other trials. Keep in mind there's more or less one trial by a big immunotherapy company, and in that setting we have, as you can see, 3 additional ongoing trials, with one having result, the Keynote 091, also called the PEARLS trial. So already 2 trials to discuss with you today. In the neoadjuvant approach, we have a pure neoadjuvant trial with immuno and chemo given before surgery and stop, nothing more, which has given results, and we'll discuss it extensively because it's a model in the field today. And we have a certain number, at the time being 4, even 5 or 6 if you look at smaller trials, what we call neoadjuvant perioperative, because after surgery you continue, usually for 1 year altogether, the immunotherapy component. So that's what we have. As you can see, 3 can be today described, but you can also imagine that in the next 2 years the whole story will be very complex because you will have all these trials, of course, with differences that we will have to manage all together to find a consensus. So let's start with the upper part, the adjuvant. Why would you do adjuvant therapy rather than neoadjuvant? What pushes you to do it after surgery? So first of all, the surgeon, because you don't impose a delay. The surgeon can resect. In some countries, the resections come before any discussion. So surgeon first. Some patients also might feel a bit better knowing that the tumor is out. It can be interesting to think that in the beginning of neoadjuvant checkpoints, people were fearing that the modification, maybe fibrosis, might make resection difficult. So there was some question mark, and you'll see it has been more or less solved. We know that adjuvant works. Adjuvant chemo saves lives. We'll discuss it later on. And in melanoma, there was this idea, and I don't think it's so right today, that immunotherapy might be better if you face a small tumor burden. So like vaccine, they work better if the tumor is small. Is it true there? It's difficult to say, but it was a concept. So this is chemo. You know it by heart. I won't spend too much time, but remember that chemo is saving lives, but not so many. It's the same magnitude as breast cancer. And absolutely, if you give chemotherapy to patients, you will save a certain number of patients with an absolute improvement of 5% of survivors long term. 5% is still significant. It's black or white, but our curves remain very bad if you look at our survival, right? We have been trying to give immunotherapy to patients. It's an old days trial already, the Magritte. Magritte was a vaccine against MAGE A3, which had given very nice results in a phase 2 trial and was tested in the adjuvant setting. And as you can see, a vaccine alone, or at least at the time it was performed, was not sufficient. And this is, as I said before, the key adjuvant trials. What I want you to look at, because we spoke endpoints, is in these adjuvant trials, all happening with the randomization after surgery, you have to keep in mind that if one endpoint is common and joined to all of these trials, is a disease-free survival. It's not very typical. You're in a curative setting. We all would like to have OS. But as I said before, we all hope that one is a surrogate of the other one, and this will bring progress to the patient faster because you can read DFS. The other thing that you have to keep in mind when we'll compare neoadjuvant to adjuvant is here's the staging is a good staging, because when you do look at your stage, you have your surgical stage. So if you say 1B, it's 1B. It's not the pets betraying you, right? So keep in mind that here's the staging is a surgical staging, which is not the case when you look at neoadjuvant, where the staging is a radiological staging. Okay? So this is one, just wanted to complete the adjuvant trials by what we call the next generation of trial. So looking at potentially customizing the adjuvant treatment, particularly the immunotherapy part, by the presence of what we call minimal residual disease, MRD, which is found in the plasma of the patient after surgery. The idea is maybe only the ones with MRD benefit from immunotherapy. You'll see later on, we are not very skilled today in being sensitive for MRD, and you will be very disappointed to learn that the MERMED-1 program was abandoned because the feasibility of such, MRD measurement is today not something that we can bring into a randomized trial. It will continue, but it's too early. Okay? So let's move to the two trials I have to present to you in the adjuvant setting. The first one is atezolizumab in the adjuvant setting. So as you can see, these are patients, we look at the 7th TNM, stage 1B to 3A. So 1B is more than 4 centimeters and 0 tumors. The idea is to, of course, we accepted in that trial EGFR and ALK. You will see the data. Of course, you let in that trial the investigator decide which chemotherapy, but remember that the chemotherapy was mandatory at least one cycle. Patients were randomized after surgery plus mandatory chemo to atezolizumab for 1 year versus best supportive care. And as you can see on the right-hand side of this slide, the statistical design, this is the charm of it. The statistical design was pretty complex. It's what we call a hierarchical design, where every endpoint, when it is met, can redistribute its alpha to the next level. It's a good way to move apart. If by mistake you miss the first step, everything is ruined. So you need to know what you do. But here it was, as you can see, the endpoint is DFS, but the DFS in positive PD-L1 stage 2 to 3. Would it be met DFS in all randomized stage 2 to 3? Would it be met DFS in the ITT, regardless of the stage, ending up with an overall survival? Okay? It's a nice strategy, but again, you shouldn't do a mistake in the order. If you look at the patient characteristic, nothing extremely special to tell you that a proportion of histological samples facing the reality, 65% of non-squamous. The PD-L1 status, as you can see here, positivity was found in almost 60%, which is what you expect in that trial. And basically, you can see the regimen of chemotherapy meeting the practice. So this is characteristic, very in line and very well balanced between the two groups with our practice. Remember the hierarchy? First population on the left, met. So more than 1%, stage 2, 3A, fine. Hazard ratio 0.66, quite stringent. Second population in the hierarchy, you just get rid of the PD-L1, and this means a hazard ratio of 0.79, still positive, but you can see that the curve get closer to each other in that population, still significant. Third population, ITT population, regardless of PD-L1, this didn't cross the boundaries for significance, so you cannot see it here, but it's immature, and this is still not considered as being statistically significant. So we stop with the first two populations. You'll see the FDA has stopped with the first one. Why? So this is the subgroup, as you can see, the forest plot, the improved forest plot. So what do you need to know? First of all, histology doesn't look to count. It's important because sometimes you have some debate about histology. Histology is the same. When you look at the stage, and here we look at the key population, the first one, stage 2 and 3 behave the same, and the nodes behave the same. But look at the PD-L1. So PD-L1 is a strange and annoying story. Strange because here, on the contrary of the second population, you can see that the positive between 1%, more than 1%, is positive, but it's marginally positive, really less than the more than 50%. And the negative PD-L1 are sitting on the one line. So that's when the FDA decided to only take the first population, right? This can be understood. So this is basically, as you can see, the best subgroup, the more than 50%. As I said before, they always benefit more. It's important to show this graph in comparison to the next trial. It's expected, but amazing in terms of magnitude of difference. 0.4 is really something that we like to see. Okay, so the one thing which is important, my ctDNA, so in that situation, it's not MRD which was measured, but they quantified kind of the amount of disease after surgery, right? Trying to see if ctDNA was predicting or not the outcome with autism or best supportive care. So what you can see in all ctDNA evaluable stage 2 to 3 patients, you can see the impact of being ctDNA positive or negative on the outcome. However, what you cannot really see is that the atezolizumab changes something, which is a little disappointing because in both ctDNA positive or negative, what you can see is that the atezolizumab doesn't really differ. I would say it is still beneficial in patients with ctDNA negative. And the other thing is, if really ctDNA measured the way it was in that trial, was really sorting patients between residual disease or not, it's not very good because the ctDNA negative, they still relapse pretty a lot for patients who are supposed. So this is about the limits of the exercise. We can still not use ctDNA to detect relapse. Treatment adverse events, don't want to stop too much on that. You know how it works. Anti-PD-L1, it was really a profile which was in line with the expectation for these compounds. Okay? So you can see some autoimmune adverse events in the organs as expected with a very modest level of pneumonitis. And early OS data, so of course, extremely immature. So this is, again, you remember the last step of the hierarchy. So you can see a trend into the positive PD-L1 stage 2 to 3A, but it's too early to read. I would guess it will transform into a positivity in the future, but it's my guess. So as I've said before, because of this negative PD-L1, it has been granted FDA approval for stage 2 to 3A, more than 1% PD-L1, the left-hand side, highest level of the hierarchy. Second trial, even stranger, the PEARLS 091. I was involved in this one, which is the adjuvant pembrolizumab. Pretty same design to make the story short. A patient was stratified by the stage and by the PD-L1, of course. And remember, chemotherapy was optional. So patients were stratified by chemo, yes or not. It was led to the investigator, okay? DFS was the primary endpoint in the overall population. And we had, this is a charm of it. A dual primary endpoint with a second primary endpoint of DFS in the high population of more than 50%. Dual means that if you meet one, you redistribute the alpha in the other one, right? So that's a nice way to potentially consider that both are supposed to be positive, but maybe not equally positive. 1 year of pembrolizumab. Okay. So this is the baseline characteristic. Against nothing very special to tell you, a small proportion of EGFR and ALK, stage issue with some as expected. Chemotherapy was delivered in the majority of patients against stage 1B and above. 15% in both arms did not receive chemotherapy. And again, distribution of PD-L1 is really as expected here. Okay. This is one of the dual primary endpoints, the DFS in the ITT. This is the message of this trial. It's positive in all comers. Hazard ratio 0.76, highly significant. But of course, it's a first interim analysis, deserve further reading. You can see the censoring, okay? And interestingly, the more than 50% do not do well. That's a problem of the trial. So if you allow me to go back one slide, I will be extremely annoying. The problem of these two curves, if you concentrate on the curve, this is not the blue curve. This is not the experimental curve, which is going up. Is you don't know why, and despite the stratification, which is pretty good and well done, the control arm in this subgroup is overperforming. I don't know why, and there's no reason, because remember, if PD-L1, if anything, it's negatively prognostic. The more PD-L1, the worst outcome you should have. So this curve is supposed the yellow to go down, and it goes up. So it's a spurious exercise of subgroup analysis. There might be many factors doing that. It's very annoying for the trial, and the alpha of this arm will not be given to the other one. So it's kind of a worry that I don't have any answer for you. If you look at subgroups apart from that, remember that here, again, as we know, we can see the result of positivity with some recovery of some subgroups. Look here. So there's one subgroup which is surprisingly benefiting is a never smoker. One subgroup which is a little bit surprisingly benefiting is the stage 1B. The stage 1B here is doing pretty well as compared to the other trial you've seen before. Remember, they were sitting on the one. And here what is quite interesting is a negative PD-L1. In this trial, the 50 do not well, but the negative do pretty well. So you complete the picture. Does it mean all patients benefit? Maybe. The other thing which is interesting, EGFR mutants also benefit. It goes a bit with a never smoker. So you recover subgroups, okay? Overall survival is extremely immature in this trial. Frozen hazard ratio today is 0.87, but it's extremely immature, as you can see with the censoring. Toxicity as expected, and that's for the adjuvant trial. You know everything, and it's a matter of questioning today. Are we going to have a table with colors? This is for Atizo, this is for Pembro, depending on the registration. We still don't know, and this data are still not submitted to regulatory authorities for the second one. Neoadjuvant. Why would you use neoadjuvant? So let's take the other way around. So first of all, because if you have the whole tumor, you can imagine in terms of antigen presentation to the immune system, it's probably good to have a lot of dying cells in parallel to the checkpoints to present to the immune system interesting neoantigen. The host and the immune system are fitter before surgery. You remember that everything you do in oncology, when you create a pressure, a negative pressure, a selective pressure, you create heterogeneity. So the problem is if you have a naive tumor, you will have less heterogeneity and more if you are in the adjuvant setting. And last but not least, it's a real way opportunity to perform opportunity trial, a window of opportunity trial to have the comparison of biopsy before, surgical sample after, microenvironment, and so on and so forth. And of course, it might shorten the completion of the trial using innovative endpoints. This is a list of trials. All of them are characterized by EFS as primary endpoint. Some of them have also pathological complete response or major pathological complete response as a secondary endpoint. MPR means that in the surgical sample, there are less than 10% of viable tumor cell, MPR, okay? So we have 816 published in the New England in parallel to the American Association, the AACR meeting. So this is a very interesting trial. And the only arms that I would like you to look at is the ones where we could read at the end is the comparison of neoadjuvant chemo versus neoadjuvant chemo and nivolumab. What was interesting there is it's only 3 cycles, maybe a little short, but 3 cycles of chemo and nivolumab. Primary endpoint is EFS and pathological complete response. These are co-primary endpoints. This is the charm of it. It means that they immediately divide the alpha between the two subgroups without any further distribution. Statistics become very interesting. Baseline characteristic, as expected, Naxin's patient half are squamous, a bit more squamous than you can imagine. And there is a high proportion of stage 3. Why? Probably because we are used to give neoadjuvant in stage 3 disease. So it might be we have favored this neoadjuvant strategy there. So this is a distribution of patients. I just wanted you to look at one glimpse I give here, which will be continued by my colleague surgeon, is that when we do this graph, there were lots of parameters measured. And one which was measured was the time of the duration of surgery. Remember, is it a problem to perform surgery? And as you will see later on, it was rather the other way around. All the surgical parameters were pretty improved by the addition of nivolumab and not worsened. Primary endpoint, co-primary endpoint, pathological complete response in every site of tumor, nodes and tumor. And as you can see, you multiply your low pathological complete response by 10. So you go from 2.2 to 24. So this is a pretty important improvement, which is seen across all stages of initial disease. So really an amazing improvement. 24 is unbelievable for lung cancer doctors, I can tell you. This is the subgroups of the patient looking at pathological complete response. So to make a very long story very short, all subgroups benefit, maybe one subgroup a little less, which are the never smokers, but all subgroups benefit in terms of pathological complete response. It's interesting to look at the patients who have a ctDNA clearance just before surgery. It's not after surgery, it's before surgery, as compared to the one who did not. So it's not really surprising to see that the one who had a ctDNA clearance had a higher major pathological complete response and a better outcome than the other one. Second co-primary endpoint, the EFS. You can see here an improvement quite impressive with a hazard ratio of 0.63 of the co-primary endpoint of EFS with this regimen, which was again observed across, statistically speaking, all stratum, all subgroups of patients. And you look maybe at one thing which is important for me is the PDL1. You can see again an incremental of benefits that follows the rule with more than 50%, but all this interval overlap, it was pretty well stratified. And remember, they all have good pathological complete response. So a high level of pathological complete response, which has led to an attribution of recognition by the FDA in all of these subgroups, right, which is pretty interesting. So stage 2, all of these stage benefit, stage 3 benefit more, but you can still see a benefit in stage 1, B2 with a pretty well-stratified trial. The exploratory analysis by pathological complete response, are you allowed to consider that pathological complete response is cure? You still don't know, but when you look at this patient with pathological complete response, it's quite amazing how they benefit more than the ones who don't. It's blue versus blue, right? And you can see that maybe we are defining here a way to predict curability of the disease. The overall survival misses maybe 2 or 3 events to be significant. So it's 0.57. It's still not significant, but it will be very soon for 816. Treatment adverse events, we'll speak about surgery, but were as expected on the medical oncology point of view. And on March 4th, the FDA approved the combination across all subgroups of this trial because it was really properly stratified, which might not have been the case of other trials I have defined before. So remaining questions that you have in mind is, of course, we don't know all the subgroups. So the PD-L1 negative, we need to see all the curves. The smoking status, the stage and histology have to be followed, but today we believe it benefits in all. How to use the endpoints, it will be discussed later on. Can you consider that pathological complete response is a surrogate of EFS and of OS? Breast cancer doctors are questioning it. Should we believe in that? We need data, but it's a question of religion at the time being. How to use ctDNA clearance before or maybe after surgery? What about other mutation, STK11, KEAP1, that might also modify the picture? Any other biomarker? And of course, the main question is, adjuvant or neoadjuvant, and why? So with this, I thank you for your attention. The conclusion is you have understood the immunotherapy in the perioperative management has changed the landscape, has changed the way we treat. Which patients who receive neoadjuvant versus adjuvant will be further studied, but probably never known. It's going to be more a consensus than an evidence of high level. And maybe additional biomarkers will help us to know if all these patients need 1 year of immunotherapy, which looks like to be not sustainable, geographically speaking. Thank you.
Okay, thank you very much. So,
Okay.
Last speaker is Dr. Boris Sapesky, and he's going to give the surgeon's perspective on all of this.
Well, thank you very much. So obviously this is a hard act for me to follow. You guys have seen all the data, so hopefully what I can contribute over here is surgeon's perspective. And I think that we live in the era where the communication between surgeon, medical oncologists, and radiation oncologists, with all the options that have, is absolutely paramount in selecting patients for these different types of therapies and really completing the treatment. So just to review, as of today, as a standard of care, we have this neoadjuvant option for patients with stage 2 to stage 3 lung cancer, obviously by AJCC 8 staging system. I'm talking about tumors that are greater than 4 centimeters in size. And let's say N2 positive lymph nodes. And let's maybe not necessarily dwell on whether it's a single or multi-station. And then we have also these adjuvant options, and obviously we have biomarkers that are important, especially in the adjuvant setting based on the ADAURA trial. We have surgery, and then obviously we also have Pacific, and Pacific specifically uses this word of what's resectable and unresectable, and who decides on that? Is it the surgeon who decides? Is it the team who decides? What sort of factors go into this? What is the best for the patient? So I think this is where we stand today. I think it's certainly very exciting that we have all these options, but I think we need to keep selecting this for our patients. So I wanted to bring up basically seven points that I think about and maybe kind of share them with you, as a surgeon, of what I think about when I see these patients and how I communicate with my medical and radiation oncologists. So the first point I would like to make, that patients do best in the long run if they can complete all therapy. So when I see a patient as a surgeon, and I'm going to have to admit that I work in an institution where, I'm salaried, I'm not incentivized by RVUs. So basically my goal is to select the best patient for the treatment, best therapy for the patient, and communicate, with my colleagues. Because if I do an operation and let's say patient has bad outcome or cannot recover and cannot receive an adjuvant therapy, and let's say the patient has stage 2 or stage 3 disease, I'm not doing a good service to that patient. And we all know, likewise, if patients fall off of neoadjuvant therapy, let's say, and then they cannot get it. So all of us are on the same boat over here. So we have to be really careful about this stratification. So I want to point this out that in Checkmate 816, first of all, the results are really amazing. This is a tremendous improvement. And in fact, if we look at how many patients were resected, the PCR rate actually wasn't 24%, it was 40%. So assuming that actually part of the criteria for the trial where that these patients were supposed to be resectable, I'm a little bit surprised by what happened with this trial and how many people fell off therapy. But it was a world trial, all right? It was done in Europe and Asia and the United States. And so I don't want to be critical, one way or the other, but in Europe, for some reason, nearly 30% of patients had canceled surgery. What happened over there? What were these really adverse events, or did we not consent the right patients over there? And then when I look at the R0 resection in the United States of 65%, that also has underperformed significantly. When we look at neoadjuvant trials, my belief is that general figure should be about 90%. Of those people who we give neoadjuvant therapy, we should be able to get 90% of them to surgery, and we should achieve at least 90% R0 resection rate. So I think that's a really important thing for a surgeon. When we look at this, it will be interesting to see what the long-term data look from this trial, based on this sort of a high R1, R2 resection rate. I also want to point out that when you do neoadjuvant therapy, there's a lot of questions about restaging. Do you have to restage? My bias of many surgeons is that you stage patients once upfront invasively with mediastinoscopy, EBUS, etc. The restaging after neoadjuvant therapy is usually radiographic, and we generally do not chase more biopsies, we usually proceed with resection. But what we learned from the NeoStar trial, which actually in the arm A and B was just nivolumab and nivo and ipi. We had other arms with chemotherapy that included this. But we saw this phenomenon of nodal immune flare, that immunotherapy can essentially create a sarcoid-type reaction in the lymph nodes. So I would caution everybody that if you see that there is progression in the lymph nodes after any sort of immunotherapy treatment, don't necessarily assume disease progression, but biopsy those patients, because it wasn't a trivial event. It occurred actually in about 16% of patients. We did publish this in the in Nature Communications, if you want to look that up. But there were additional patients who actually had granulomas on their final pathological specimen. So restaging is important, but trust your original plan. It's more likely that the patient is not progressing and maybe has something else. You know, another question is what is the resectable disease? And we'll get to this with the case, but you know, generally, even if you think that patient may be marginally resected, discuss it with your surgeon. The surgeon really should be able to read their CT scans better than radiologists, to look at every structure, the bronchus, the pulmonary artery. And as a surgeon, you kind of have the three-dimensional picture of when I get there, where's this going to be? How can I do this? Can I do this open? Can I do this with robotic assisted? Can I do it VATS? You know, what should I do? I need to control the pulmonary artery to make this safe. So there's a lot of thinking that goes on in terms of the conduct of the operation just by looking at the scan. Make sure that you have, you know, PET scan and a good IV contrast scan to look at the pulmonary artery. And this is just a little anatomy review. I didn't have any sort of bloody videos over here, but this is a really kind of a nice picture that you guys may have seen long time in the medical school. But this is what a surgeon sees in the anterior hilum. And depending on where the tumor is located, the surgeon has a picture on the CT scan. You know, how close is this to the phrenic nerve? Where is the recurrent? Where is the aorta? Where is my superior vena? Where is my? This is the left side, so not SVC, but superior pulmonary vein versus inferior pulmonary vein. And likewise, the lymphatics over here, you know, the standard is really to extensively sample, or I would say dissect, at least 3 N2 stations. So on the right side, it's a little bit easier because you have level 9, level 7, and 2 and 4, which are peritracheal lymph nodes. On the left side, sometimes maybe a little bit tricky because the 5 and 6, the level 6 lymph nodes are right around where the recurrent comes around, right there, right over here, around the arch, and you have a main PA afterwards. But these level 5 lymph nodes are always consistent. Level 7, you have to go really underneath there, and level 9 usually you get. So you know, don't judge your surgeons by the approach. If you're going to challenge your surgeons, challenge them based on the completeness of resection. R0 resection, so adequate margins and adequate nodal dissection. So 3 N2 stations and 1 N1 station. Whether they make an incision, you know, in surgery, there's always some kind of jokes and some kind of saying, you know, big incision, small surgeon, small incision, big mistakes. So, so, you know, but we do, the field of surgery has truly advanced. You know, we have video assisted techniques through smaller incision, great visualization. We have different anesthesia. We have local anesthesia with the blocks, with Exparel. And so patients generally go home after about 4 days. And so some of the measures that were mentioned over here, there was a time to the operation of the operative time for 816. Well, if there were more thoracotomies performed, and they were actually about the same, but that 20-30 minute time is probably about just the closure of the incisions. It seems like there were more minimally invasive cases and less conversions between chemo IO and chemotherapy in 816. These are important findings. The trial wasn't really powered to this. I would not. I think these are excellent trends. I think we'll figure out what they are kind of in the future. The one thing that was really brought up, that there were less pneumonectomies with chemo IO, and that's true. If you're going to have more responses, you may save more patients from a pneumonectomy. But I still would caution surgeons, and I would caution providers to assume that you can go on this type of a treatment and that you will have a response and then you will save the operation. I don't think that we can promise that to patients. And so that's where the judgment comes. Like if I feel that a patient would require pneumonectomy, and especially if there's N2 disease, and especially if it's on the right, I would go Pacific route. If it's on the left side, we could potentially debate if there's a level 5 lymph node and excellent pulmonary function test. But because we have these other options, you know, we can kind of decide that really the best outcomes are with lobectomy and mediastinal lymph node dissection. The rest of the outcomes with surgical complications, they were about the same. What I wanted to highlight over here is that There were probably some differences amongst healthcare system or how providers, even though they had criteria for this Checkmate 816 trial of who to enroll and who not to enroll, obviously, in the trial, and I completely believe they followed them. But you can just see that, our usual length of stay at our institution for a lobectomy is 3.6 days. So this 4 days sounds about right. Why patients stayed in the hospital 9 or 11 days in other parts of the world, I think that's something that maybe will come up that some investigators from the trial will talk about this. And I also wanted to point out that we would wish that if there is a response, that the response comes away from the major structures, right? Because that's what we as surgeons need to divide. So if I have a tumor that is a budding pulmonary artery, I wish that tumor shrank away from the pulmonary artery so I can get around it easily and get a good margin. Unfortunately, cancers seem to find a way to respond their own way. And so this is, again, the point that when I look at the images and when I look at what type of operation patient would need, I really kind of make it based on the original staging and original scan. And this is where intraoperatively communication with the pathologist is extremely important, because as we think about scaling back the type of operations from pneumonectomy to less, we don't know what this tissue is. This may be still an inflamed tissue from chemoimmunotherapy. And so it's important to send frozen sections from some areas, because if there is no viable tumor, then we can perform lesser resections. This is just to demonstrate that today it's extremely important. Obviously, if we considering neoadjuvant therapy, we have to rule out EGFR and ALK mutation. Otherwise, we cannot really proceed with this 816 regimen. And so, depending on the place, it's not always a trivial thing. To get tissue depends on who does it: pulmonologist, surgeon, interventional radiologist. So we have to be really kind of attuned in that and change our workflow a little bit to enroll patients in neoadjuvant trials. And I just want to mention that there are tremendous efforts through LCMC4 and LEADER trial to profile patients. And in metastatic setting, we have all the drugs for all of these mutations, and there are trials currently ongoing to try to enroll patients in neoadjuvant setting based on these drugs and based on the mutations. And this is just a schema for the LEADER trial, and there are numerous trials enrolling patients over here. And so, I think I'm slowly running out of time here, so I'll run through this a little bit quicker. We were going to discuss these cases, so we'll talk about that. This was mostly about that neoadjuvant therapy really allows us to do research. Just like Dr. Peters mentioned, we give neoadjuvant treatment, and then we can look at response rates, and then we can really try to sort out who the responses are. And I think I will close there. Thank you.
So now there are some updates in the relevant studies here that are being presented or at ASCO. These are being presented on Monday. This is a neoadjuvant Nivo plus platinum doublet, a Checkmate 816 update, late-breaking abstract, and then the Pearl study also an abstract on Monday. So these are surgery cases.
Okay. So I can go. This is one of my patients. So this is a 60-year-old male who was diagnosed with adenocarcinoma of the right upper lobe. And in fact, I showed you this. I showed you this picture over here. I showed you the staging. So he was staged as a T3N1. There was a tumor that was really extending from the right upper lobe bronchus into the bronchus intermedius. His MRI of brain was negative. He didn't have any N2 station disease, but essentially 3A disease. He was a former smoker. He was EGFR and ALK negative. Excellent pulmonary function test. He could have tolerated right-sided pneumonectomy. But when I looked at this, I maybe thought, that potentially surgical resection could be, but based on just that scan, what type of treatment would you offer, just based on what you saw over there?
So chemoradiation, chemo-IO followed by surgery, chemotherapy followed by surgery, chemo-RT followed by surgery, upfront surgery followed by adjuvant therapy, and Dr. Bramer's favorite, I'm not sure. Give your opinions on these answers. Boris?
So I communicated about this patient with again with our medical oncologist, and really this came down to the judgment that I felt that in the worst case scenario, pneumonectomy would be possible. This patient, I thought the right upper lobe sleeve, really, since there was no N2 disease, perhaps if there was N2 disease, maybe I would push this a little bit more to the Pacific protocol. But we did treat these patients with chemo-IO. With the plan to perform surgery. Actually, this patient was on trial as well, received 3 cycles, very similar to the 816 regimen. I wonder.
What do you think about the chemo RT followed by surgery option?
Yes, so there's an institutional bias. I know, University of Toronto, and I know that, for example, Swedish. In Seattle, they used to have a lot of bias with chemoradiation followed by surgery. I know that other institutions really thought more about, chemo followed by surgery. I think a lot of data, even with chemotherapy, didn't necessarily demonstrate benefit. That if the surgeon can achieve an R0 resection, then I don't think there is any role for doubling down on the local treatment. I think what we're really trying to achieve here is some kind of a tumor regression and prevent metastatic disease, and local regional control will be done surgically. That's where the judgment comes. I don't think there's a reason to do that. Plus, I know that PORT now with the ALT trial kind of fell out of favor, but it is better to save radiation for maybe slightly positive margin if that sort of occurs. So we have not been using chemoradiation followed by surgery as a paradigm.
Comments, Dr. Bramer?
Well, I guess since there was not N2 disease, then we lean against chemo RT. Our radiation oncologists like doing that for N2 disease, but I think based on the NADIM-2 study that was presented earlier today, I'd push back and have them consider chemo IO followed by surgery. I guess one question I had for our surgeon is about pneumonectomy. Do you give any pause about giving chemo IO followed by pneumonectomy in these patients?
Not necessarily. I think first of all, we shy away from pneumonectomies just as a general rule. I would say, especially on the right side. Now, if there are patients who are who have exceptional physiologic status, I think that's how I would make the decision. I think left-sided pneumonectomies may be a little bit better tolerated, but I think when I look at pneumonectomy, I look at what can I achieve with the pneumonectomy relative to the extent of the disease, and what are my other options. But just because patients receive chemo IO, that is not a deal breaker. I think it really comes down to patient's physiology.
Dr. Peters?
I would also probably use the 816 because remember, this patient is interesting because he's resectable. He's obviously operable too, but I would say in order to avoid a pneumonectomy, being able to pursue with your sleeve resection, he should not progress because you would be in trouble. So before 816, at the age of chemo only, remember, progression rate under chemo induction was 20-25%. In 816, the progression rate is 7%. So the risk is low. It does not inexisting, but it's low. But for me, it's acceptable. Chemo versus chemo RT, we do the randomized trial published, not making me younger, probably 10 years or 15 years ago in the Lancet, where we compared 3 cycles of chemo plus minus neoadjuvant radiation. And as you said, what is the conclusion of all this multimodality treatment is one local, perfectly well-performed strategy is enough. An optimal local treatment is enough. So I would never give radiation there. But now I would feel confident, 7% risk of progression, that chemo IO might be the good solution for these patients. The question we will have is, what hope did you have to minimize your risk of surgery and your extent of surgery? Sometimes the surgeons give us incentive telling that they could minimize the surgical risk or the surgical, I would say, extent, and that's an additional incentive for the patient quality of life later on.
So the bottom line is the entire world has changed with the release of 816 data. I mean, these answers are completely different now than they would have been 6 months ago. Mm-hmm. So let's go ahead and vote again, see what people think. Were we convincing or confusing?
Well, this case sort of continues. So you guys gave this type of treatment. So you give this regimen, and this was your response. So this is after 3 cycles of chemo and nivolumab that you decided to give, and then you restage the patient with a PET-CT scan, and this is what you get. The bronchus is now open. There is no visible disease. There's this little tiny area of FDG uptake right over here. And you know what to do sort of in this situation. And I'm not sure that we have I don't know if we have questions following this, but I mean it's certainly a question for a surgeon. But I would be interested to hear from our panel or from others. I guess we do have questions over here. So what would you do at this point? It looks like there is basically clinical complete response. So would you do observation alone because of clinical complete response, do surgery as planned, which was sort of a sleeve resection? Would you consolidate with radiation treatment? Would you try to obtain tissue to prove there is tumor there? Or would you do more systemic therapy since the patient has been responding so well? So go ahead.
So you have to realize that this is very new. And a lot of the answers to these questions have not been directly tested in trials. I do think consolidation radiation is not the right option here. Could you ever imagine a world in which a complete response with neoadjuvant therapy would not result in surgery? I think not now for sure, but maybe down the road. That's even a possibility. The biopsying, I think, would be very risky because with a dramatic radiographic response like that, I think you'd be very likely to miss real cancer if it was there. So I'm not sure I would base a decision on a rebiopsy. And the decision about more systemic therapy after surgery is still an open one. We don't know if even in the presence of a complete pathologic response, whether adjuvant gives additional benefit. So I would do surgery as planned.
Yeah, we are not melanoma doctors. We can't tell anything about the meaning of complete response in lung cancer. Would it be with IO or chemo? We never have shown that complete response being pathological or radiological means cure. We need to show that. Maybe I'm perfectly wrong and it's going to be the case, but we still need to prove it, that complete responders will not relapse. The reason why breast cancer doctors have been questioned about the pathological complete response is because they lost the certainty that after chemo IO, if you have PAT-CR, some of these patients relapse later on. So you need to make sure it's not the case. So I would go for surgery in this patient. Rebiopsy, it's a good question. I always tell to my young doctors in my institution, never do a biopsy if at the end you don't trust your biopsy, right, and you have the same question again. So here you do your EBUS, it's negative, and you say, well, we should do surgery anyway. Yeah. So never do a biopsy where the value of the biopsy is not only, I mean, you do
if
a biopsy
you're not going
to
act on a test, don't do it.
Exactly.
Right. Dr. Bramer?
Yeah. Well, interesting, just referring back to ASCO earlier today with the results in rectal cancer where they showed, like 15 patients with MSI high rectal cancer that received IO as single agent before considering either neoadjuvant chemo RT or surgery, and they had 100% response rate. Obviously, they were not rectal surgeons, but they have better ways of assessing response and than we do in thoracic surgery. But still, I think the answer here is go on to surgery and make sure we've got everything.
All right. Should we revote?
Yeah, we did resect this patient. He had pathological complete response. And just from my standpoint, since my originally planned operation was a sleeve lobectomy, I didn't want to submit him to, because it's an advanced technique. You have to cut the right mainstem bronchus, suture things together, put a muscle flap, etc. I decided to actually cut the bronchus and send it for a margin. And we have really excellent thoracic pathologists, and they saw no more tumor. I really felt that that I should not keep operating more on this. And patient was well aware that, he had lobectomy. He's now alive 3 years later without recurrence. He did not receive any additional therapy afterwards. We didn't know what to do at that point. So here's another case, though. So this is a 65-year-old male, kind of a similar thing. He came with a kind of a similar tumor, T3 and 0 on the left side. It's kind of hard to say whether level 5 lymph node is involved there, but brain MRI was negative. He was a never smoker. And I just put here just for the discussion, EGFR negative, but also excellent pulmonary function tests and PFS. And so what would you do based on what you saw for that patient? Would you treat him again with the Pacific? Let's say he's stage 2, but you can't really tell. You can't really biopsy those N2 lymph nodes at level 5. So is he stage 2 or is he stage 3? Or would you do chemo IO the same way, followed by surgery, chemotherapy, or again, chemo RT followed by surgery? Or would you just tell the surgeon, hey, why don't you just go resect this and then tell me what it is, and then we'll figure it out afterwards. So go ahead, vote on this, please.
I think chemoradiation Pacific would not be unreasonable, but in the current era, I think chemo IO followed by surgery would be appealing to me as well.
I should have said the surgeon felt that based on the other images, CT scan, that this could be taken care of with a lobectomy.
Yeah.
Yeah. So Julie?
It's a surgical patient, right? So we have strong surgery in some countries. For the surgeon, it's a patient who is resectable. But thinking about the old days medicine, it's potentially, let's say it might be an N2. So in N2, we liked, it may be all days data, but we like to give the chemo in neoadjuvant. We had these old trials. It was the time you could publish in New England with 60 patients, but neoadjuvant was giving better results than adjuvant. So on the old days, thinking about the opportunity of giving adjuvant chemo IO, stage 3 would still fall in the category of, if I can, I prefer neoadjuvant in order to clear the mediastinal lymph nodes, maybe improve the prognosis. At least that's what all data were telling. Not sure it's right at the time of IO, but this is what I would still apply.
Dr. Bramer?
LCMC4 neoadjuvant. I have a feeling that they may harbor some type of mutation, or fusion, but I would stick with the chemo IO followed by surgery.
Okay,
so that's our panel. Let's revote, I guess.
So that's what we did. I mean, we gave chemo IO, but this is what happened. I mean, so this is after 3 cycles of chemotherapy plus nivolumab. This was done on trial. PET-CTs can actually show no response to therapy. You can actually see that there's maybe a little bit of an uptake at level 4L lymph node now. You have maybe some uptake with post-obstructive, maybe a little bit of post-obstructive pneumonia. I mean, this is the type of scenario I was talking about, is the level 4L lighting up a little bit because of a little bit of a pneumonia, a little bit of an infection, or do we overinterpret this as potential disease progression? So after 3 cycles of chemo IO, that's the CT scan. What do? Do you talk to your surgeon, just say, hey, just go take it out. Let's switch and let's go with chemo RT. I guess I have had a couple of, so it's either or, obviously.
All of these trials actually were designed for patients that were operable up front, in the opinion of the multidisciplinary team. And so this is a patient that historically would have gotten surgery up front. So I think that the argument, in my mind, would be for sure surgery, but then the question of whether or not additional adjuvant is needed is an unanswered one, because all of the current randomized neoadjuvant chemo IO studies all use adjuvant. 816 doesn't, and we don't know whether in 816 the patients who did not get a path CR didn't get a huge amount of benefit from the neoadjuvant chemo IO, not significant.
And we know in immunotherapy that they are very, very good responders, probably the one who survived 5 years. But for the other ones, we know from not the best trials, but that there might be a question of duration of IO. And stopping too early might be detrimental. It's not the best responders and not the top of the curve, but the other ones might need a certain exposure to anti-PD-1, anti-PD-L1. So that's my fear about 816 is I'm not so sure that 3 cycles of checkpoint is enough. And I'm not sure for sure that I'm ready to think 3 is enough if the response is that way or that way. I need to, so somebody shows me it's enough, right? So it's going to be difficult to compare, but it's nice because BMS decided to make the same trial with a longer time, which will probably help us understanding the contribution of the longer time of IO. But I don't like this 3 cycle. I must say, I'm in Switzerland, I can do whatever I want. So I tend to give a bit more than 3 cycles of IO.
Yeah, and so we can look at the non-path CR subset in the ongoing trials, and if there was a benefit that suggests adjuvant help, but it's not a head-to-head comparison, it's a cross-trial comparison.
And also compare the complete pathological response.
Of course.
Is there a way to prevent the small number of relapse, which will happen, right, by continuing the IO longer?
Yeah. Dr. Bramer, what do you think in this case?
I think we're kind of stuck probably going straight to surgery and then deciding, depending on what we see under the microscope, decide whether or not you feel comfortable stopping versus giving something else. I'd be really torn and really want to push hard on the insurance company if it's not an MPR. I'd be really nervous about leaving this person without any adjuvant therapy.
I'm not sure what the insurance approval would be with neoadjuvant. In this case, if you decided to give adjuvant pembro or adjuvant atezo, they'd probably get denied.
Mm-hmm. Yeah.
All right, let's go ahead and vote again. Surgery is planned or surgery followed by adjuvant? I think both reasonable cases.
Mm-hmm. I think we can probably combine those answers. So again, I think that Dr. Carbone made an excellent point over here that when we now strategize about these patients, I think this is where surgeon, medical oncologists, radiation oncologists really just need to meet up front and say, we're going to choose this strategy. And it's going to be, I think, unlikely to deviate from that. As you can see, the scans can look kind of weird after chemo, immunotherapy, but I think that if the surgeon truly felt that this is a resectable disease, I think patients should be given benefit of the doubt and at least have put a scope inside his chest to make sure that there is no metastatic disease or something like that, because it's unlikely that even after 3 cycles that are given every 3 weeks, so that's 9 weeks plus another 3 weeks, let's say, to plan an operation, that the cancer, there would be such a significant hyperprogression. People have talked about hyperprogression, but biologically it doesn't always necessarily make sense. And if the patient was healthy enough for a lobectomy up front, I think the patient should be given benefit of the doubt, because you really truly find out. I mean, we say operating room is the temple of truth. And so that's where you really find out what you have. Dr. Peters talked about the fact that final pathological staging truly really tells you where you stand. And so complete resection was achieved over here. Margins were negative. This was a YPT 3 and 0. The only question is that this patient did not respond to your induction therapy. What to give this patient now? And I think we kind of alluded to that. And
yeah, that's a real question that we kind of touched on. But if they didn't respond to chemo IO, is more chemo IO going to help them? So
I'm not sure about more chemo. He received probably 3 cycles. You want to add an additional cycle where there was probably slight progressive disease? I would just do more IO.
Yeah, and then as we just heard, sometimes you go into with intention to operate and you find pleural implants or some other reason why they can't be resected. But it was good for this patient that wasn't the case. All right, let's go on. This is an adjuvant study. Did you want to do this or should I?
I think
go
this
ahead.
Is your case.
It's not your case, but not my case either.
Okay.
But this is a 55-year-old Asian American with a extensive smoking history. Presents with hemoptysis, right upper lobe mass, 4.9 centimeters, solitary right hilar lymph node, brain's negative, PET otherwise negative. And this is a guy who went to surgery. Right upper lobectomy was performed with an R0 resection. It was adeno, high PD-L1, driver negative, G12A mutation, 1 positive hilar lymph node. So he received adjuvant chemotherapy and tolerated it well, and the pathologic stage was 2B. So then the question here is, what would you do in the modern era with this patient? High PD-L1, driver negative, complete resection. positive Hyler node. So let's vote. I think that that's a very reasonable answer in this patient. Adjuvant atezo. Now, why pick atezo over pembro? I don't think there's a lot of rationale, except the subsets were very weird in the pembro study, and the high PD-L1 group didn't do as well. But it's a subset analysis.
It's a primary endpoint. So when you will have to attribute a score for this endpoint, it's at the time being, it's a bad score. So I agree, atezolizumab, level of evidence, has a higher level of evidence and magnitude of benefit.
Yeah. Dr. Bramer?
Oh, definitely adjuvant atezolizumab. Again, I do have that question about the high PD-L1 for pembrolizumab, but you could do either. Particularly now in a patient with stage 2 disease, I think giving another year of therapy is the appropriate.
Yeah, great. And we haven't even touched on, IO exclusion criteria, but clearly those exist in clinical practice. Okay, re-challenge question. What do people think about atezo, pembro, surveillance, or adjuvant radiation and IO, or I'm not sure. So we have a bunch of questions from the audience and online. I think maybe we can just we are over time, but I think we can touch on them. One question was in the INSIGNA trial, which is randomizing PD-L1 greater than 1% metastatic patients to pembro versus pembro chemo. And then additionally, if they randomize to pembro, it randomizes them on progression to adding chemo versus switching to chemo. And I think those are all really interesting questions. And that study is about half accrued, is that right, Dr.
Right.
Bramer, something like
Right.
that? And I think that will directly allow us to ask certain questions about, what subsets of patients might benefit from IO monotherapy, but also importantly, what to do on progression of IO monotherapy, whether to add chemo or switch to chemo. So I don't know if we need additional discussion on that. It's an ongoing clinical trial that I think is a high priority.
Please enroll.
Please enroll. So another question is, does neoadjuvant immunotherapy replace radiation therapy for stage 3A disease? Dr. Peters, what do you think?
Well, I was thinking about the last slide you had before, the place of radiotherapy as being neoadjuvant or adjuvant has almost to be banned, I would say.
Neoadjuvant.
Yeah, well, neoadjuvant or adjuvant for me. This role of radiation in the neo or the adjuvant setting, thanks to the trials which have been performed, to me does not exist anymore. Radiation is definitive, or it's complementary when you have residual disease, an R1 or an R2, which is not adjuvant. Remember, adjuvant means that you don't know if you have a disease. So what I mean is, for me, neoadjuvant radiation has been proven to be grossly and in randomized trial not a strategy to adopt. So does neoadjuvant IO replace radiation? No, because for me, radiation has gone, but it's still the new standard of care.
Yeah, I would agree with that. And Dr. Bramer is nodding as well. How is pathologic response defined in lung cancer? So in my mind, the most definitive definition is PathCR, that if there's no tumor on careful sectioning, that's a pretty clear result. Major pathologic response is much less clear, especially since you don't have a good assessment of the fraction of tumor pre-treatment. Many lung cancers are 30% tumor before you treat them at all. And it is a more difficult judgment call to judge the fraction of tumor cells if there are still existing tumor. But typically, as Dr. Peters said, it's defined as 10% in clinical trials. But to me, really, the biggest decision point is PathCR or not. And so let's just go. Should oncologists or surgeons pre-specify what they want the pathologist to report, or do you leave it up to the pathologist? I guess in the current era, it's not standard of care in an operative report to report percent tumor. in the result. They'll usually say it's there or it's not.
Well, I guess maybe it's institution dependent, and I do work at MD Anderson, so our pathologists do report percent viable tumor for all patients who receive neoadjuvant therapy. So that is part of what our pathologists do. But I mean, every pathologist should know what needs to be reported, and surgeon and pathologist should really communicate. There's a lot of discussion about the number of lymph nodes. It's not necessarily the number that's important; it's the stations. So the stations, really, the surgeon needs to mark these stations in the operating room and send it to pathology and say, this is level 10, this is level 7. Nothing like this is a peribronchial lymph node or this is a hilar lymph node. We do have numbering schema, and that's how it should be reported by the pathologist, and surgeon needs to send it to pathology as such.
Yeah, I agree. And now the next couple of questions are quick, I think, and I'm just going to take a stab at it. So what do you do when these perioperative IO treated patients relapse? Do you try first line IO chemo or whatever? I think that's an unanswered question, but I would say right now I would use standard first line metastatic therapy with chemo IO.
I would use 9LA.
You would use what?
I would use a CTLA-4 combination, depend on
you
that.
Would use
but
it,
I would try to re-challenge to depend, of course, of the time of progression and potentially the interval between. But I might believe we have some little melanoma data here again that maybe the dual inhibition might give rise to a new response. Why not trying if you have the opportunity to do that? First line metastatic.
So you're convincing me. I think that's a very reasonable option. Dr. Bramer, do you have a input in there?
You could do bevacizumab, atezo plus chemo. You could do that as well based on some very extrapolating from the second line data that we heard from Dr. Reckkamp showing that pembrolizumab plus of VEGF did seem to have response at the time of resistance.
Well, the bottom line now is we don't know, because this is a new era in lung cancer treatment, and sometimes it's guided by insurance decisions, because I've had patients who had perioperative IO, then relapse, and then the insurance denies IO in first line.
Really? So it depends on this insurance system. We define the line, so we first line metastatic, which helps.
Yeah. So what's the potential role of MRD testing? I think we're all excited about possible ctDNA use to decide on additional adjuvant therapy, but those are questions that are being tested currently, and we don't have a robust enough ctDNA data to make decisions right now, I would say. Are the decisions between neoadjuvant and adjuvant stage dependent? In other words, if you had a 3A, would you be more inclined to use neoadjuvant or 1B?
Scientifically speaking, if a difference has to be seen between neoadjuvant and adjuvant, it's not going to be about the stage. It's going to be about the biology of getting early versus late immunotherapy, fitness of the immune system, neoantigen load, and so on. So it's not going to be stage dependent. But here you are speaking about habitudes. How much will it be easy to convince a surgeon to let you the time to give neoadjuvant chemo IO if you have a small stage 1B as compared to a big stage 3A or 3 stations and 2. So what I mean is probably more about the interprofessional dialogue, depending on the future data to come, what you can negotiate as being neoadjuvant or adjuvant. And we've seen the bias, more squamous, more stage 3. We have in mind that neoadjuvant is always still fitting a bit more the locally well-advanced disease. But probably in the future, we need to adopt consensual strategies. What do you think?
So the issues are more psychological than biological.
I mean, the way I talk to patients is that once they have stage 2 disease, I tell them that the therapy that you will need is local therapy and systemic therapy. And how we sequence the therapy doesn't necessarily matter. If I have a smoker who I want to stop smoking and who has stage 2 disease and I want to do some prehab, I would say, you're going to tolerate this better up front. Let's give you an upfront treatment. We do have that bias a little bit at my institution, so I will admit that. But as a general rule, the higher the stage, the more towards neoadjuvant. But I would give neoadjuvant to anybody who I feel clinically meets criteria for systemic therapy somewhere in the treatment.
Yeah, and I have a bias toward neoadjuvant in general, but Dr. Bramer, what do you think?
No, I agree. I have a bias towards neoadjuvant, but for very small tumors, I think a lot of them will escape my grasp and go straight to the surgeon.
Might be.
Okay, a question about what to do with EGFR mutant lung cancer. If you know someone's EGFR mutated, I would say you should not give IO neoadjuvant.
Correct.
Other
I agree.
disagreements?
No.
Question is what to do if you know someone is ROS mutated or BRAF mutated. There's unanswered questions because those are very small subsets of the current trials, but my inclination is also not to use IO in those patients. BRAF may be an exception if the person's a smoker, but that's...
Or Metaxon 14 when he's a smoker.
Right.
So the two.
Right.
Dr. Carbo,
Yeah.
I think we should conclude.
Oh, please conclude. Okay. I'm getting the hook here. So I think we need to conclude. They're probably going to kick us out of the room soon. So I really would like to thank you for listening to us. I think we've had a very robust discussion and a complex area of cancer therapy. And I appreciate all your questions, and I'm sorry I didn't get to all of them. So thank you very much.
Thank you.
Thank you.
Thank you for listening. Download materials and complete the post test for instant credit at peerreview.com/RGK860. This activity is supported through educational grants from Bristol Myers Squibb, Genentech, a member of the Roche Group, and Merck & Company, Incorporated.